Welcome back to the Deep Dive, the place where we tackle the foundational texts of clinical knowledge, slice them open, and really extract the most critical insights you need. Today, we are opening up a real cornerstone of modern patient care. We're doing a deep dive into the essentials of health education and health promotion.
That's right. And we're pulling directly and exclusively from the framework laid out in Brunner and Sutter's definitive medical surgical nursing textbook.
So our mission today is to build, what? The clinical blueprint for wellness.
That's a perfect way to put it. We're treating this chapter as a comprehensive guide to understanding how a nurse, functioning as an independent practitioner, educates and motivates patients.
Right.
And, for anyone in healthcare, recognizing that health teaching isn't just an add-on, but an essential independent function of nursing. Well, that's where we have to begin.
And that recognition is huge, isn't it? This material really confirms that effective health teaching is the solid foundation that individual, family, and community wellness is built on.
It is. It's the difference between a patient, passively receiving care and actively managing their own health destiny.
So to set the stage for this blueprint, we first have to lock down the vocabulary.
We do. These 5 terms structure the entire approach, and honestly, they're frequently confused outside of a formal clinical setting.
Okay, so let's clarify those core concepts immediately. What's the real distinction between education and promotion?
Let's start with health education. This is the specific, structured action. It refers to the various learning experiences designed specifically to promote behaviors that facilitate health.
So it's the delivery of info, the skill-building part.
Exactly. Think of it as the process. Then you have health promotion.
Which is the bigger picture.
It's the overarching goal, yeah. It encompasses all activities, including education, that assist people in developing resources to maintain or enhance their well-being and improve their quality of life. Education is a tool for promotion.
Got it. Okay, next up, the concept that really determines success. Adherence.
Adherence is the process of faithfully following guidelines or directions, usually for a prescribed therapeutic regimen.
Like medication schedules, diet restrictions, that sort of thing.
Precisely. And it requires active participation and commitment from the patient. It's not passive.
Then, a really critical contemporary challenge for all health systems. Health literacy.
This one is so important. It's defined as the capability of an individual to obtain, communicate, process, and understand essential health information.
And that's fundamental, right?
Yeah.
It's needed to get care and to make decisions.
Absolutely. If that capability is compromised, the entire health relationship just breaks down.
Okay, and wrapping up our foundational vocabulary, the context for all of this, community.
The textbook keeps this definition simple. It's an interacting population of individuals living together within a larger society. Recognizing that scope lets a nurse move from teaching one person to impacting population health.
Perfect. So with those terms down, let's explore why this is also critical. You said this is an independent nursing function mandated by professional standards.
Absolutely. The requirement to teach is not subjective. It's mandated by every single state Nurse Practice Act.
Wow, every single one.
Every single one. And what's more, the American Nurses Association's scope and standards of practice explicitly identifies health teaching and health promotion as independent functions of nursing. You're as obligated to teach as you are to safely give a med.
So that means every interaction is a teaching opportunity, even if the patient is acutely ill or just in for a routine check.
That's the key shift in perspective. All nursing care is geared toward promoting, maintaining, or restoring health. And the nurse is the primary conduit for ensuring the public has a right to comprehensive, up-to-date health info.
Especially now in the age of Google, where you can find anything, but not all of it is good.
Exactly. The nurse's role is increasingly to help consumers filter the noise, find trustworthy, credible internet resources, and identify appropriate practitioners.
This role becomes exponentially more critical when we talk about patients with long-term conditions.
Oh, absolutely. The role of health education in managing chronic illness is arguably where its value is highest. As people live longer, the prevalence of chronic illnesses and disabilities just rises.
And those individuals need that focused education.
They need it to actively participate in and assume responsibility for their self-care. Without quality, targeted teaching, they struggle to adapt, they can't carry out complex therapies, and critically, they are unable to prevent complications.
Which means they end up in crisis situations that land them right back in the hospital.
Exactly. Preventing those crises and reducing rehospitalizations from inadequate self-care information is a core goal. The ultimate objective is to empower patients, to teach people how to live a healthy life and strive toward their maximum health potential.
And that leads directly to the powerful economic case for patient teaching. It's not just ethical, it's financially smart.
It is profound cost avoidance strategy. When nurses effectively teach patients to manage complex therapies, we prevent illness, we decrease unnecessary interventions, we shorten hospital stays.
Facilitating earlier, safer discharge. I mean, think about heart failure or diabetes. Structured education is proven to lower 30-day readmission rates.
Which is a massive cost saving, and there's an impact on the healthcare agency itself, too.
Right. Patient satisfaction scores.
Which is now a major reimbursement and quality metric, yeah. Strong education programs build positive public relations, and a surprising point from the source is that those positive staff-patient relationships can actually help avert malpractice suits.
Interesting. So education is a professional mandate, an ethical necessity, and a cost-saving imperative. With that established, let's tackle the biggest hurdle, non-adherence and the barrier of low health literacy.
Okay, so we've defined adherence as faithfully following the therapeutic regimen, the meds, diet, exercise, all of it. But the reality is adherence rates are generally low.
And it gets worse when the regimen is long-term or complex, or for conditions that are asymptomatic like hypertension.
Precisely. Long-term regimens for things like chronic inflammatory diseases, HIV, cardiovascular risk, they all show significant rates of non-adherence. The key clinical insight here is that there is never a single cause.
It's a complex web of factors.
It is, and nurses have to assess these factors across 5 distinct categories.
Let's break those down. First, the fixed characteristics, demographic variables.
So these include the patient's age, gender, race, education level, socioeconomic status. You can't change these, but they are crucial indicators that tell you how you need to deliver the education.
Like if someone has lower literacy or financial constraints, you need simplified materials and resource coordination.
Exactly. Next, you have illness variables.
This is about the condition itself.
Yes, the severity of the illness and, critically, the immediate relief of symptoms that the therapy provides. If a patient feels no tangible benefit from a therapy, say an oral chemo with bad side effects, motivation just plummets.
So the perceived threat of the illness has to be balanced against the perceived benefit of the treatment.
The third category is the logistical burden, therapeutic regimen variables.
The treatment plan itself.
How complex is it? Multiple doses per day, strict timing. That complexity directly correlates with non-adherence. We also include treatment fatigue here, just the weariness of managing a long-term condition, and side effects.
The fourth category, psychosocial variables, seems to cover, well, the vast inner world of the patient.
It's the most complex and often the most challenging. It includes the patient's intelligence, their motivation, their support systems, competing life demands like work and family.
Their attitude toward health professionals, acceptance or denial of the illness.
All of it. Plus ingrained religious or cultural beliefs and substance abuse issues. These can completely derail adherence no matter how physically capable the person is.
So denial of a chronic illness isn't just a mental state, it's a direct barrier to action.
A huge barrier. They can't even get to the starting line. And the final category, financial variables, is often the hard stop.
Because no matter how motivated you are, if you can't afford the medication or the equipment,
adherence is impossible. That's right. The direct and indirect costs can be insurmountable. So a nurse has to assess this early and be ready to connect patients with social work or financial aid.
that 5-part model gives a really solid structure for finding all the potential points of failure.
It does.
So let's drill down into health literacy again. What are the very real, dangerous consequences of low health literacy in practice?
The consequences are severe. Low health literacy is strongly correlated with poor overall health. If a patient lacks these skills, they can't safely share personal health info, they can't perform self-care management like adjusting insulin doses.
They can't navigate the health system or even fill out forms correctly.
Right, or even calculate the sodium on a food label for a cardiac diet. It essentially locks them out of their own health management.
So what specific strategies must nurses use to actively improve health literacy?
It has to be integrated into every step. At the individual level, the nurse has to use plain language, avoid all medical jargon, and use effective communication.
And on a broader scale?
We have to design and distribute materials that are not just accurate, but also culturally appropriate, using images and language that resonate. And beyond the bedside, nurses must build community partnerships and advocate for systemic policies that promote a health-literate society.
It sounds like a long-term structural obligation for the profession. So moving from capability to desire, you mentioned knowledge alone is never enough. We have to address motivation.
Motivation is the spark. It's what turns knowledge into behavior, and research shows it's strongly linked to the personal relevance of the strategies.
The patient have to feel that the regimen is important to them.
Yes, and it's linked to their perceived control over their health, the type of problem they're facing, and the quality of the patient-provider relationship.
So how do we operationalize that motivation? The chapter highlights a powerful tool, the learning contract.
The learning contract is a formal written agreement. It's based on the assessment data, the patient's needs, and most importantly, specific, measurable goals. And the structure is critical.
The goals have to be realistic and positive, starting small and progressing.
Exactly. Incrementally.
Can you give us an example of how that works in a contract?
Sure. Instead of a vague goal like, I'll cut sugar, a learning contract goal would be, I will achieve a measurable weight loss of 1 to 2 pounds per week by walking 30 minutes, 5 times a week.
Budget specific.
Very. And the contract includes methods for evaluation and built-in frequent positive reinforcement for every small milestone. That success fuels motivation for the next bigger goal.
Okay, let's focus on a population where non-adherence is a major problem. Older adults.
It is. Non-adherence is a major contributor to increased morbidity, mortality, and cost in the gerontologic population. Hospital admissions, transitions to nursing homes, they're frequently linked directly to it.
And there are specific compounding factors that nurses have to look for when educating an older patient.
There are. First, complexity. They're often managing multiple chronic illnesses, which leads to polypharmacy, tons of medications.
And physiological changes.
Increased sensitivity to meds and their side effects, making it painful or challenging to adhere. Then you have psychosocial factors. Difficulty adjusting to change, financial constraints, maybe a lifetime habit of self-treating with over-the-counter stuff.
And we can't forget sensory and cognitive impairments.
Absolutely. Visual or hearing impairments require specific techniques, and crucially, the nurse has to assess for cognitive impairment, which can prevent the older adult from being able to draw inferences or even understand the main points, no matter how clearly you say them.
So the nursing imperative here is holistic care coordination.
Yes. The nurse has to do a comprehensive assessment of strengths and limitations to encourage compensation. And maybe most importantly, ensure continuous, coordinated care across all health professionals.
Because it's so common for hospital nurses teaching to be contradicted by an outpatient provider.
Incredibly common. A single, clear, coordinated plan is vital for this population.
That seamless handoff of information truly defines success. Okay, let's pivot from why we teach to how we facilitate learning, the nature of the teaching and learning dynamic itself.
So we establish that learning is the active acquisition of knowledge, and teaching is helping someone else acquire it. This emphasizes that the process is inherently active.
The nurse isn't just a transmitter of facts, they're a facilitator.
A facilitator of the learning process, exactly.
And the optimal moment for this facilitation is defined as learning readiness.
It's the optimum time for learning, the teachable moment, and it corresponds precisely to the learner's perceived need and desire for that knowledge. And for adults, readiness is complex. It depends on 4 major assessment factors.
Let's start with how culture acts as a filter for readiness.
Culture encompasses a patient's values, ideals, learned behaviors. It's the whole framework they use. It heavily influences how people learn and, critically, what health practices they're willing to accept.
So if a nurse's teaching conflicts with a patient's culturally mediated values,
the teaching will likely be rejected. So, nurses have to perform an individual cultural assessment, not rely on broad, often inaccurate generalizations.
And what about their personal values regarding health?
The nurse has to understand the value the patient places on their health. If the patient doesn't value the specific health outcome you're promoting, they just won't participate.
Makes sense. Next, the immediate physical state. Physical readiness.
This is non-negotiable. A patient who is in acute pain or has severe shortness of breath or is nauseous. They are physically incapable of focusing, retaining, or processing new info.
Trying to teach, then, is just inefficient and frustrating for everyone.
Right. Manage the symptoms first. Then there's the complex area of emotional readiness.
This is often linked to acceptance or denial.
It's tied directly to their stage of acceptance of their illness. If a new regimen conflicts sharply with their lifestyle or self-image, they might consciously avoid learning about it.
And while we should assess for this readiness, we often can't just wait for it to appear.
Sometimes we can't. The nurse may need to proactively stimulate motivation if emotional readiness is absent.
Can you give a practical example of that?
Sure. Imagine a patient who just got a terrifying cancer diagnosis, but they also have dangerously high blood pressure that needs immediate management. They might be consumed by the cancer, denying the immediate danger of the hypertension.
So the nurse has to gently but firmly guide them to recognize the short-term danger to stimulate readiness for that specific topic.
Exactly. And once that environment is established, we need tools to ensure the teaching actually landed. The chapter strongly advocates for the teach-back technique.
This is probably one of the most practical and essential patient safety tools.
It is. Teach-back is an in-the-moment evaluation method. The nurse asks the patient or caregiver to explain the information back in their own words or to demonstrate the skill.
And it's so much better than just asking, "Do you understand?"
Oh, worlds better. Because it places the responsibility for clear communication on the nurse. If the patient can't teach it back accurately, the nurse knows immediately they need to rephrase or clarify without blaming the patient.
Right. We also have to look at experiential readiness.
This involves their educational background and life experiences. A patient who lacks basic knowledge in, say, nutrition will struggle with a complex dietary regimen. The learning has to be familiar and meaningful.
And before we get into specific techniques, the learning environment itself has to be optimized.
We have to minimize all sources of interference, room temperature, lighting, noise levels, and crucially, make sure the patient is using their glasses, their hearing aids, before you start.
And timing is everything.
Yes. Avoid scheduling sessions when they're fatigued, uncomfortable, or anxious, and avoid teaching when visitors are present unless the family is actively involved in learning the skills.
Okay, readiness and environment are optimized. Now we select our teaching techniques and resources.
Traditional methods include lectures, which are okay for delivering information, but they must be followed by discussion for clarification.
And group teaching.
That's excellent because it provides information efficiently and offers moral support. But you have to do follow-up to make sure that general info translated into specific learning for each person.
And for procedural skills, it has to be hands-on.
Demonstration and practice are essential. And the crucial rule here, a point that cannot be overstated for patient safety, is you must use the exact same equipment that the patient will use at home.
So if they're practicing an insulin injection, they use the exact syringe or pen they're taking home.
The exact one. Using different equipment causes confusion and increases the risk of mistakes.
The chapter also highlights more modern conversational approaches like motivational interviewing.
Yeah, pilot research cited in the source suggests that using motivational interviewing, even in acute care settings, can significantly increase patient and caregiver knowledge and improve self-care adherence.
And then, of course, we have electronic online information and classic teaching aids like models and pamphlets.
When you use those aids, you have a professional responsibility to review them beforehand. The key clinical alert is to make sure the materials are free of confusing ads, culturally appropriate, and actually meet the patient's specific learning needs.
Let's turn now to a dedicated section on educating people with specific disabilities, which requires tailored strategies, often based on that Table 3.1 guidance.
This requires a lot of adaptation. For patients with general physical, emotional, or cognitive disabilities, the teaching must be simplified. Clear written and oral info highlight only the most significant points and no medical jargon.
And for the hearing impaired.
If the patient can speech read, the nurse uses slow, deliberate speech and positions themselves directly in front of the patient. If it's a unilateral hearing loss, you speak to the good ear, and you rely heavily on written materials, visual aids, and interpreters.
How do we adapt teaching for sensory disability, particularly visual impairment?
The strategies focus on maximizing other senses. We use optical devices, proper lighting, sharp color contrast. Information has to be converted to auditory or tactile formats, talking books, or braille.
And there's a critical procedural step.
Yes, arranging all materials in a clockwise pattern and explicitly explaining the location of each item. You also have to explain equipment noises, since those can be startling.
What about learning disabilities?
For an input disability, like a visual perceptual disorder, the nurse focuses on verbal methods. Explain, repeat, use audio tapes. For an output disability, where they struggle to process or respond, we focus on speaking slowly, maintaining eye contact, and using visual tools like demonstration and return demonstration.
And finally, developmental disability.
The foundational rule here is to base teaching on the patient's developmental stage, not their chronological age. Use nonverbal cues, simple concrete explanations, and rely heavily on active participation and repetition.
That detailed approach confirmed that patient education is a sophisticated, highly adaptive process. So now we wrap all these tactics into the overriding clinical structure, the nursing process.
The entire framework of education in nursing relies on the structured approach of the nursing process. Teaching is an intervention implied by all nursing diagnoses.
And for some, like impaired health maintenance or decisional conflict, it's the primary intervention.
It is the primary intervention.
So let's break down the application of the process, starting with the foundation, assessment.
Assessment is systematic data collection focused entirely on the learning needs and readiness of the patient. You identify all internal and external variables, health beliefs, literacy support systems. That data gets organized to determine what the patient needs to learn and when they're most receptive.
Step 2, formulating the nursing diagnosis.
This step provides clarity. A specific diagnosis, like deficient knowledge related to new medication regimen, guides the whole process and gives you a basis for evaluation later.
Then we move to planning, the blueprint for teaching, which has 5 critical sub-steps.
Step 1, assigning priorities. This has to be collaborative. Critical needs, like survival skills for a diabetic, always come first.
Step 2, specifying goals. And here's that crucial concept: mastery alert goals must be established before you decide on teaching strategies.
Absolutely essential. The goals must be mutual, realistic, and achievable. Third, you identify specific teaching strategies. Fourth, you specify expected, measurable outcomes and the time periods for attaining them.
And the final planning step ensures continuity.
Step 5 is the complete documentation of the plan. We also have to meticulously structure the content, critical information first in a logical sequence.
Moving to implementation, the action phase.
This is the active execution. It requires a ton of flexibility and creativity to use the right aids, maintain motivation, and use language they understand. And again, use the exact same home equipment.
And finally, the crucial step that closes the loop, evaluation.
The evaluation determines how effectively the patient responded. And we have to remember, learning does not automatically follow teaching. We have to use objective data to determine what worked and what needs to be reinforced or changed.
And how do we generate that objective data?
We use a blend of techniques. Direct measurements include observing the patient perform a skill using checklists. Indirect measurements are things like oral questioning, written tests, and satisfaction surveys. Using more than one enhances reliability.
And evaluation doesn't stop at discharge.
It can't, especially with short hospital stays. It has to extend into aftercare, requiring close coordination between hospital and community nurses. And the information you get is never an endpoint. It's the beginning of a new assessment.
That systematic framework gives us the tools for immediate needs. Now we expand our lens to health promotion, the pursuit of maximum wellness.
Right. Health promotion is all about encouraging people to live maximally healthy lives. And this isn't just a clinical nicety, it's a national health policy cornerstone, driven by the need to control costs and reduce unnecessary sickness and death.
And this is codified in the Healthy People 2030 mandate.
Yes, the initiative has 2 main goals. First, increase the quality and years of healthy life for everyone. And second, eliminate health disparities. All health promotion efforts in the U.S. are benchmarked against this.
And the philosophy centers on the person's potential for wellness.
It's an active process. It can't be prescribed. The individual has to make conscious, deliberate choices. The nurse's role is to facilitate that empowerment.
To understand those choices, the chapter introduces several health promotion models, starting with the classic health belief model.
This model helps explain why some healthy people choose preventive action and others don't. It says behavior is influenced by 4 categories of variables: demographic and disease factors, barriers, resources, and crucial perceptual factors.
And those perceptual factors are entirely internal.
Exactly. The patient's view of their health status, their self-efficacy, their belief in their own ability to do the action, and the perceived demands of the illness.
We also have the resource model of preventive health behavior.
This one is based on social learning theory. It emphasizes motivation and explores how cognitive perceptual factors influence a person's view of health. It assesses perceived control, self-efficacy, and the balance of benefits versus barriers.
Then there is the AMSO model.
AMSO stands for Awareness, Motivation, Skills, and Opportunity. This model helps people balance the 5 dimensions of optimal health: Physical, emotional, social, intellectual, and spiritual.
So if a person lacks the skills or opportunity to exercise, for instance, their physical health dimension will suffer.
Precisely. And finally, we have the Transtheoretical Model of Change, or stages of change, a foundational framework for motivation.
This one is so vital because recognizing the stage dictates the right nursing intervention.
It absolutely does. There are 6 distinct stages of motivation to change behavior.
Okay, walk us through those 6 stages and how the nurse's intervention changes.
Stage 1 is precontemplative. The person is genuinely not thinking about making a change in the foreseeable future.
So the nursing intervention here is just raising awareness, not demanding action.
Exactly. Stage 2, contemplative. Now they've begun to think about it maybe in the next 6 months, but they're still weighing the pros and cons.
So our intervention is to validate their perspective and help them explore the benefits of change.
Tip the decisional balance, yes. Stage 3, decision-making or preparation. They're constructing a specific plan to change, usually within the next month.
So now we help them set specific goals and develop a concrete action plan.
Right, like that learning contract we talked about. Stage 4 is action. The person is actively operationalizing the plan.
So the focus shifts entirely to support, coaching, and positive reinforcement.
High levels of support, yes. Stage 5 is maintenance. They've sustained the change for 6 months or more and are working to prevent relapse.
So support transitions to peer-based support and developing coping strategies.
And stage 6 is termination. The person can completely resist relapse. The unhealthy behavior is no longer a temptation. The intervention there is minimal celebration and follow-up.
Understanding those stages allows the nurse to stop wasting time on action strategies for a pre-contemplative patient.
It makes the clinical application incredibly clear.
Okay, let's look at the 4 core active components of health promotion identified in the chapter.
These are self-responsibility, nutritional awareness, stress reduction and management, and physical fitness.
Starting with self-responsibility, personal accountability.
This is the foundation. It rests on the idea that individuals largely control their lives and must make choices to avoid high-risk behaviors, smoking, alcohol misuse, and so on, and adopt positive routines.
Next, the single most significant factor, nutritional awareness.
Research repeatedly underscores that good nutrition is the single most significant factor in determining health status, longevity, and weight control. The key guideline is to substitute natural foods for processed ones and consciously reduce sugar, salt, fat, and additives.
The third component is stress reduction and management.
Stress has profound negative effects on health, linked to infectious diseases, injuries, and the exacerbation of chronic illnesses. Stress management uses techniques like relaxation training, exercise, and yoga to strengthen a person's resources.
And the final component, physical fitness.
Regular, individualized exercise, started gradually and increased slowly, provides comprehensive benefits across all body systems.
And what are the specific, measurable physiological benefits the chapter details?
Oh, there are many. Improved circulatory and lung function, a decrease in total cholesterol and LDL, effective weight management, a delay in degenerative changes like osteoporosis, and improved flexibility and strength.
This dovetails perfectly with a fascinating nursing research profile in the chapter, focusing on emerging adults with inflammatory bowel disease.
Yes, the study looked at how social support affects self-management in that transitional age group, 18 to 29.
And what was the key finding for these IBD patients?
The major finding was that the emerging adults who reported receiving high informational support, so structured information from nurses, group interventions, peer mentoring, they reported significantly greater adherence to their medication regimen.
Interesting. So the other types of social support didn't correlate as strongly?
Not with medication adherence, no. So the nursing implication is clear. Structured, formalized informational support is paramount for this age group.
Let's expand on the strategies required throughout the lifespan, because health promotion starts before birth and continues through old age.
For adolescents, the goal has moved beyond simple screening. The focus is on promoting positive health attitudes, values training, building self-esteem, encouraging healthy lifestyles that are fun and relevant.
And for young and middle-aged adults.
This is a highly receptive group, often motivated by family and career. Programs focus on general wellness, fitness, weight control, parenting, and screening for major chronic diseases like cancer and heart disease.
The workplace has also become a huge setting for health promotion.
Huge. Employers support these programs because of rising healthcare costs, absenteeism, and lost productivity. So you see health screenings, fitness facilities, nutritional campaigns, all at work.
And finally, revisiting gerontologic considerations for health promotion.
Even though most older adults have one or more chronic illnesses, they see significant gains. Most are highly health conscious. The key benefit is maintaining independence and achieving an optimal level of health. The programs are the same core components, just adjusted for their capabilities.
To bring this all back to practical clinical reference points, let's review the select adult health promotion screening and immunizations detailed in the source.
Okay. These are evidence-based but always require mutual determination between the patient and clinician. For screening, routine health exams are usually annual. Blood chemistry and lipid profiles are suggested for baseline at age 20. Hemoccult screening is generally yearly after age 50.
And the key cancer screening timelines.
Mammograms are typically recommended yearly for women starting at age 45, then transitioning to every 2 years for women 55 and older. Colonoscopy is recommended every 5 to 10 years after age 50, unless there are high-risk factors.
And the essential adult immunizations the nurse must promote.
The annual flu vaccine, that's non-negotiable. The hepatitis B series, if they haven't had it, and the HPV vaccine up to age 26. Tdap is every 10 years. The zoster, or shingles vaccine, is recommended for adults after age 50.
And there are specific guidelines for the pneumococcal vaccines for older adults.
Yes, this is a key teaching point. For adults 65 and older, the guideline involves the sequential use of PCV13 and PPSV23. If they haven't had either, PCV13 should be given first, followed by PPSV23 at least 1 year later.
This comprehensive list really confirms that health promotion isn't abstract. It's deeply integrated into the specific preventative clinical practice guidelines nurses follow every day.
It connects every aspect we've discussed. Education is the tool that ensures adherence to these guidelines, which in turn achieves the goal of health promotion.
Let's bring this deep dive to a close by reinforcing the nurse's central and vital role in this entire structure.
Nurses must initiate and actively participate in health promotion programs. They're accessible, they have expertise, they have credibility. Every single interaction is an opportunity to foster well-being.
Our entire conversation today has demonstrated that health education is the intervention that drives adherence, and adherence is what ensures long-term wellness.
Exactly. The essential takeaway is that using the systematic structure of the nursing process and understanding the complex human behaviors described by those health promotion models allows us to fulfill our ultimate clinical goal.
Teaching people to live a healthy life and strive toward their maximum health potential.
That's it.
So to leave you with a thought to consider as you move into clinical practice, we spent a lot of time on the Transtheoretical Model of Change. Think about the massive clinical difference between a patient in the contemplative stage, thinking about quitting smoking soon, versus a patient in the precontemplative stage who isn't considering it at all.
Your assessment and intervention for the contemplative patient should focus on building an action plan and weighing pros and cons. But for the pre-contemplative patient, your time is best spent just raising awareness of the health risks. Applying those models practically is how you bridge that gap between textbook theory and successful individualized patient outcomes.
That's a powerful framework for prioritizing your limited time at the bedside. Thank you so much for joining us for this comprehensive deep dive into the clinical blueprint for health education and promotion.
Always a pleasure to break down these essentials.
We'll see you next time on The Deep Dive.